Welcome back to Your Health radio and television program. I'm Dr. David Morwood. I'm a board-certified plastic surgeon, and my next special guest, Dr. Patrik Zetterlund, cardiologist. Dr. Zetterlund, thanks very much for joining us.
Thank you for having me, David.
Really appreciate you being here. Dr. Zetterlund, what I'd like to do is talk a little bit about what a cardiologist does and the training that you've gone through to become a cardiologist, and I want to talk about this very important issue, cardiac cath. So let's talk about how you become a cardiologist.
Well, as everyone else, as a physician, you go through medical school and then you become an internist. You spend 3 years in graduate training to become a board-certified internist. And after that, you decide, do you want to go to fellowship? Do you want to be a cardiologist? And you make a commitment for another 3, 4, 5 years of postgraduate training and a fellowship training, and you become then a cardiovascular specialist. You don't stop there. You can then go on and do additional training, i.e. what I do. I'm an interventional cardiologist. You spend another year or two for that specialty, or you can become a heart failure specialist, an electrophysiologist, or now we have imaging specialists that just specialize in images of the cardiovascular tree.
So, Dr. Zetterlund, I want to go over that again. So you first essentially become a trained doctor. I mean, you become an internist. Mm-hmm. And then you select a specialty, cardiology, and you do more training within that.
Correct. It's the same as if somebody wants to be a gastroenterologist or a pulmonologist. You're an internist. You're an internal medicine specialist. And within that, you can then specialize in an organ system, cardiovascular disease.
Okay. So let's go over your typical week or your typical day. You're an interventional cardiologist. And so what's your day like?
Well, my work week is about 60 to 80 hours a week and involves a lot of call. I thought when I wanted to first be a cardiologist that this would be easy, but you know, cardiology has changed. Now we treat individuals with heart attacks by they have to go to the cath lab 24/7, because in the old days, if somebody had a heart attack, you come in and you would just lay down and have your heart attack. We know in our specialty that it's changed profoundly, that we truly take these individuals and take them to the angio suite at 24/7. So my job is really not an 8 to 5 job. It's when you're on call, you're always available, like I am today, right now. And there's a group of us that cover the county, both hospitals here in Monterey as well as in Salinas. So our typical day is being available at any time to take care of individuals that have these acute coronary syndromes, which is a heart attack. In addition to our office, just like you would be in the office of the other physicians here, in managing patients. So it's both. Being in the hospital in an instant moment, but also being in the office.
Okay. Now, Dr. Zetterlund, you know, I want to really educate our viewers about what you do. So you mentioned heart attack. We call that a myocardial infarction, of course. So let's talk about the specifics of that. We know that the heart is the organ primarily responsible to pump blood throughout the body, but the heart muscle itself requires blood. Isn't that right?
That's correct.
So how is it that the heart muscle itself gets blood?
It's quite easy. Your heart is a circular tuberous muscle that beats like this. On the outside of the heart, the arteries are like a spider web. And you know from the base of the heart where the aorta is, the arteries branches out around. So outside the heart are these arteries as circulating on the muscle, squeezing with the heart muscle.
Okay, so there are arteries that actually supply blood to the muscle of the heart itself.
Correct.
Now, you know, as a surgeon, I have only a rudimentary knowledge about this, but if we think of the lub-dub of the heart beating, isn't the lub pushing blood through the body, and during the dub phase, that's when the heart itself gets blood supply? Is that true?
Well, the heart in systole, that is when it squeezes blood out into the system. That is, the valve opens and blood comes out into the system.
Okay.
Actually, the heart does not get any blood.
Okay.
When the heart relaxes in diastole between the heart zones, is actually where the blood flows in the arteries to the heart.
Okay.
That's contrary to any other part of the body.
Okay. So can we explain briefly, I know it's actually very complicated, but can we explain briefly what is it during a myocardial infarction or a heart attack? What's happening to the heart muscle? I mean, what's going on there?
Well, first, we didn't understand that until somebody was very clever and stuck a little camera inside an artery when somebody actually had a heart attack. And we're actually able to see that what happens is that you have plaque that we know comes from cholesterol, and this plaque actually ruptures. It becomes a raw wound. And you know what happens when you have a raw wound on the surface of your skin? You seal it up, little platelets. We know those things that plug up. Same thing occurs inside the artery But obviously that has a devastating effect, because if this happens in a little pipe artery that's supplying blood to the heart muscle, it shuts down. There's no blood going to the heart muscle.
Okay, so in spite of the fact that the heart is bathed in blood and pumping blood, the muscle of the heart itself is denied a blood flow.
Correct.
And can go on to become, what we call it, ischemic, right?
Ischemic, actually what happens is that ischemic is a relative word that you're not getting adequate blood flow.
Okay.
What happens in a heart attack is that you have a complete cessation of blood flow in that particular artery. It shuts down, and metabolism changes immediately inside the heart muscle, and that's that pain that you feel.
Okay, so can the muscle actually die, or it just becomes stiff? What happens to it?
Both. If there is cessation of blood flow, no blood flow is going to that part of the heart, the muscle first becomes stiff, and you start hurting, because all these chemical reactions that occur are very complex to explain, but you and I both understand it. If blood flow ceases for more than about 20 minutes, the muscle starts to die.
Okay.
And that comes back to what I said. You have only so much time to
20
fix it.
minutes?
After 20 minutes, the muscle starts to die.
Okay. Now, Dr. Zetterlund, before we get on to the cardiac cath, and I know you're an expert in that, just to educate our viewers, how do they know whether or not they're having, when they experience chest pain, how do they know whether it's cardiac ischemia, or whether they have heartburn, or they worked out at the gym too much that day? If they feel chest pain, should they just go to the emergency room right away? I mean, how do they know?
It's a very good question. And the angina, as we think about, if you like medical history, you know angina doesn't mean pain. It means air hunger. The number one sign that you have a heart problem is shortness of breath, an inability to take a deep breath. And I take that as the greatest warning sign when a patient comes to me and says, you know, I was doing fine, but now I feel like I hit a wall. I just can't breathe. Think heart first, and then think lungs. Pain is probably only present in 40 to 50% of the time. And we talk about classic pains in the chest, going down to the arms, sweating and so forth. And all those are good symptoms. Air hunger, number one. If you're short of breath for no good reason, and it's sudden, and it's change in energy level, you should see your doctor.
Well, you know, we want to do some public service today, so I think that's important to emphasize. So anyone with shortness of breath, that's urgent. They shouldn't wait to make an appointment next week. Absolutely they should call their doctor or go to the emergency room.
Correct.
Okay. Dr. Zetterlund, before we go on to talk about cardiac cath, you know, we're going to keep people's privacy intact, but I know that you helped someone out very important to this program and actually did their cardiac cath, and I know I got rave reports about you, rave reviews, and I appreciate you coming on the program. Thanks so much.
Thank you very much.
So, Dr. Zetterlund, let's fast forward to this idea of the cardiac cath laboratory or cardiac cath lab. So let's teach our audience about the cardiac cath lab. What's that all about? What do you guys do? Well,
cardiac catheterization laboratory is not unlike an operating suite. It's a sterile environment, and there is a table that the patient is placed upon, and a mild anesthetic administered. It's done while the patient is awake.
Okay.
And as I said to my patients, a colonoscopy is a much worse experience. And you know what? The ones that have both will agree. It's done under local lidocaine that's used for numb up the skin, because you know we are not cutting in someone. We are actually accessing a blood vessel, being it in the groin area or being it in the arm area.
Okay, so see, that's something that I want to emphasize. So you guys can actually get to the heart vessels through the groin, near the hip, or through the arm.
Correct.
And you pass a catheter up?
Correct. The catheter is now thicker than the tip of your ballpoint pen. It's about 3 millimeters in diameter. So essentially you end up with an IV that's about 1/10 of an inch diameter inserted into the blood vessel in the groin. And the groin, the blood vessel is only about an inch below the skin surface. It's very easily accessible for a trained cardiologist. And you have no pain fibers on the inside of your blood vessels. And you can snake a catheter up inside any blood vessel in your body and you won't feel a thing. So the only thing that a patient may feel sometimes is a little bit of a warmth from some of the dye that we inject, which is becoming less and less because our dyes are changing. So the procedure is essentially a pain-free procedure.
Okay, so I want to teach our audience about this. So people go to the cardiac cath lab and you inject dye that goes into the cardiac vessels, right? So what can you tell from the dye? I mean, why do you do that?
Well, dye is only part of what we can do. The dye itself, yes, it outlines the vessel, But that's only the tip of the iceberg, because the dye is not going to go inside the vessel wall and tell me if there's a problem inside the blood vessel wall, because you know the blood vessel wall is a living thing with very different functions.
Okay.
It will tell me if the arteries are narrowed. That is what I explain to my patients, if it's like an hourglass, you know, the sand trickles through, you can see that.
Right.
But this is, again, just the tip of an iceberg. So we have other techniques. We have what they call intravascular ultrasound. These are ultrasound crystals that we can snake inside the arteries, which then can acoustically penetrate the vessel wall and give us information about the character of the artery or the disease state for that matter.
Okay, so let's say that someone comes in the emergency room with chest pain and they're rushed to the cardiac cath lab, and you do your dye study or your ultrasound study and you show a narrowing or a clot. So then what do you do?
Well, it's quite simple. First of all, you identify the problem, as you say. You will see a clot. And we administer medication systemically and also into the coronary artery to dissolve the clot. And I tell my patients like Drano, because it has the same purpose. It dissolves it, and it sets up the milieu for these platelets not to be as angry and try to plug up the artery. What I have done, which may have been somewhat out there aggressively, but I believe in it, and it has been verified by studies, is I suck the clot out. I said it's no good to leave a clot in there or let it go downstream into the heart muscle. So we actually have this special catheter with our little tiny vacuum cleaners. So we actually go in and we vacuum out that clot that we talked about. And then after that, we treat the blockage with the stent, which everybody knows what it is, this little metal scaffold that then springs open the artery and becomes an implant.
Well, I want to make sure that everybody does know what a stent is. So again, a stent is a little device that goes inside the vessel and helps to scaffold it open.
Correct.
Right?
Correct. Remember in the old days when we did just balloon angioplasty? We just put a balloon in, we blew up the balloon, and we pushed the artery apart.
Yes.
Half the time that artery just collapsed on you because of the muscle in the artery wall and the plaque itself. So we devised essentially what you said is a metal scaffold. That is, this stent sits on a balloon and springs open. And when the balloon goes down, the metal stays up.
Okay.
And the balloon is removed. And now you have this tube, a hollow tube that looks like a chicken wire mesh.
Okay, and again, this is all done remotely, either from a little groin access incision or an incision in the arm, and you sort of snake up the catheter, and you can work remotely like that.
Well, actually what it is that through the catheter we insert a little wire, which is very maneuverable, and things then are tracked over this wire. And that, I think, was the hallmark and the breakthrough how we can do these things. There were some very brilliant engineered physicians that designed these things. So it's a 14,000 of a wire, and over this wire we can then put the balloon down, we can put the stent down, we can put our vacuum cleaner down, we can put our little cameras down.
Amazing. Now, Dr. Zetterlund, let's say we get to the point where you take out a clot or you open up the plaque. Can we call that hardening of the arteries? Is that's essentially what happens from high cholesterol or hyperlipidemia? Person gets a clot and you open that up and put in a stent. Now, I know that some of those stents are coated with sort of an aspirin or a heparin. Some of them have different coatings. Now, are there controversies? Are there different stents that are available? How does that work?
It has become a controversy, and we could spend hours on it, but let me try to distill it down for you and the audience. Initially, these stents were of so-called bare metal, that they were made out of chromium alloy of iron metal, and they didn't have any chemicals at all. What they did is sprung it open, and the body laid down scarring. And you know, 40% of the time in 6 months, people come back with a new plugged-up artery because the body would react. So these chemicals that were put on are essentially chemicals that were used to treat cancers with. We told the cells in that part of the artery, with chemicals, don't grow back. Okay, that was good. What happened then is the stent was left without any scarring over it. It's still naked, and the body's looking and saying, wait a minute, this is foreign. And our little friend, the platelet that we all know, which is this scavenger that likes to coat foreign things, forms a clot acutely, and you can have a heart attack in these drug-coated stents. Why did that happen? It happened because there's a medication that everybody that gets a stent called Plavix, and there's soon another one to come on the market, that prevents these platelets to be sticky and plug up. If you stop taking this medication, you make yourself vulnerable. So the key is that if you get one of those drug-coated stents, you're on Plavix, and in my opinion, you're on that medication for life. And then it's a great product. So then you have to make a decision. Do you want to be on a medication that thins your blood for the rest of your life?
Okay. So if you place a stent and people go on Plavix, then they stay on that probably forever.
If they have that drug-coated stent, in my opinion, they should. I have seen 2 patients of mine that stopped it after a year and a half because the surgeon says, I'm going to do surgery on you, and they end up in the emergency room because their stent shut down on them.
Okay. Well, Dr. Zetterlund, we only have about a minute and a half left. I want to give out either a website or a phone number, and then I have a couple more important questions for you. Now, that's Patrik Zetterlund, Zetterlund. And should I give out a phone number, or do you have a website where people...
We have both. Our office number in Salinas is 758-2100, and we just also opened an office now in Ryan Ranch on Lower Dale. Use the same phone number, so we're available both sides. We also have a website, cccardio.com, and it's Central Coast Cardiology. It describes our services, the people that work, my partners, and more information.
Okay. Now, Dr. Zetterlund, we've talked about that kind of acute situation where someone goes to the emergency room with chest pain. Let's talk about the person who has a heavy family history of, say, heart disease. They've had their cholesterol measured and their HDL and LDL is kind of out of whack. Is there ever a place for elective cardiac catheterization or a workup, or do you do other tests to, say, assess someone's risk? Let's say someone's never had a heart attack that they know of, but they want to assess their risk. What do you guys do?
That's what we do every day. Somebody has high cholesterol. They come to my office. I'm in my 40s. My dad dropped dead at age 50. You look at the cholesterol, and the first thing is that you can't change your genetic predisposition. As I said to him, you can't fire your parents, but let's do what we can do. We test the cholesterol more detailed than you may think. We actually go through more genetic predisposition, look at subsets, and see how aggressively should we treat them. There are new methodologies like coronary calcium scoring, coronary CT angiography, but nothing actually beats risk factor modification, smoking cessation, treating your high blood pressure, and treating your cholesterol, healthy lifestyle. Those are tremendous investments for the future.
Well, Dr. Zetterlund, it's terrific. You're a wealth of knowledge. Thanks for coming on the show, the program. I hope you come back again. We could talk for hours, I'm sure.
Absolutely. I'd be delighted to.
Dr. Patrik Zetterlund, thank you so much. I'm Dr. David Morwood. I am a board-certified plastic surgeon, and this is Your Health radio and television program. Thanks very much for being here. Please join us again. Terrific. Thanks very much.